Most, I would like to thank you all for attending this lecture. As we were discussing in the initial chat room, this idea has been born out of the request of some students to have some refresher teaching, medical students to have some refresher teaching, and I felt it was best to carry out this teaching, but make it open to those who can join. And I hope the teaching session provides some refresher knowledge and maybe some inside knowledge to younger colleagues as to different aspects of medicine. Today, we are going to talk about the symptoms and signs of gastrointestinal disorders. I am Dr. Theodore Ngatchu. I'm a consultant gastroenterologist at the University Hospitals, Birmingham. Specifically, I work out of Heartlands and Solihull hospitals. I have been a consultant for over 15 years in the UK and a specialist gastroenterologist for over 20 years. Now, I think if we want to talk about symptoms and signs of GI disorders, it's good to just refresh our memory what we're talking about in terms of the GI tract and the gastrointestinal system. So if we look at the slide that we have up, you will see that the gastrointestinal system goes all the way from the mouth right down to the anus. To make life easy for gastroenterologists, we like separating this into three parts. So we have the upper GI tract, which goes from the mouth to the ligament of Treitz. We have the lower GI tract. Usually the lower GI tract is consisting of the colon and the anus. And then we have accessory organs. This includes the liver, the pancreas, and at times we can include the spleen. Now, if you look on the right-hand side, you will see a better arrangement of those organs. Now, that information that I gave you, if we consider the upper GI tract, the symptoms that can be attributable to the upper GI tract includes regurgitation, odynophagia, dysphagia, heartburn, dyspepsia, abdominal pain, which is a bit ubiquitous, nausea and vomiting. We also have hematemesis and melena. There is one symptom that I have not included in this list, and that is eructation. That is because I would like to talk about eructation in a different piece. So the lower GI tract symptoms consist of flatulence and bloating, constipation, diarrhea, abdominal pain, rectal pain, and rectal bleeding. Those are the common symptoms we have from the GI tract. We do have symptoms from the accessory organs, okay? And those symptoms we include jaundice, weight loss, pruritus, and some non-specific symptoms like loss of appetite and the likes. Given that for this session, I'd like to consider it as being very interactive, can members of the audience tell me if anyone knows any symptom that I've omitted? Highlight it to me, maybe in the chat. Right, I don't seem to be able to identify anything in the chat. So I will continue. Now, personally,
Dr. Theo, someone has answered you in the chat.
I don't think I can see that.
Eugenie has said abdominal pain.
Yes, abdominal pain was in one of the slides, which I said was ubiquitous. It's a common GI symptom, or the most common GI symptom, but it can refer to both upper and lower abdominal tract, upper and lower GI tract. Now, I think the medicine that I was taught in medical school still stands, although the way we practice it will change. And this is mostly referring to the younger colleagues. I think that medicine, the way we practice medicine is going to change. But the way I was taught in medicine is that you understand the symptoms, you understand the signs, and then you associate the symptoms and the signs to come up with a differential diagnosis. Okay. And then from your differential diagnosis, you carry out investigations. Now, the way medicine is actually going today, I think people will find out that the symptoms, the patients will have their symptoms. They probably will be keying that symptom into an algorithm, an artificial intelligence algorithm that will tell them what investigations they need to make a diagnosis. Very likely, some of the signs we find today on examination, we might not be doing that in the future because technology is probably going to be doing that aspect of medicine for us. And I think it's important that the junior colleagues understand these things in any case, because they will be the people to actually face the patients. And the patient might get their symptoms or signs wrong, and the colleague will be the person to actually correct that. So I would like to take some time to explain the various symptoms of the upper GI tract and the lower GI tract before proceeding. So I will start with regurgitation. It's very important. Regurgitation actually is effortless expulsion of upper GI contents. So the word effortless is very important to distinguish regurgitation from vomiting. Okay. Regurgitation is usually positional. Okay. And because it is regurgitation, it is likely to be coming from the upper digestive tract. It is likely to indicate esophageal pathology. Okay. And the common causes of this include an esophageal diverticulum, achalasia, or a hiatus hernia. Now, odynophagia refers to painful swallowing. So the patient walks in, sorry about that. The patient walks in and complains of pain on swallowing. Usually this pain is identified retrosternally, is a retrosternal pain, okay? At times the pain can be severe to mimic a cardiac pain. Just bear with me, let me switch off my phone. Okay, so some of the common causes of odynophagia are esophagitis, esophageal spasm, and malignancy. Dysphagia is another symptom attributable to the upper digestive tract. And dysphagia is actually difficulty swallowing. So that is, the act of swallowing becomes impeded either by the food not progressing or the food getting stuck. Okay. And you can hear the patient tells you, "Doc, I feel my food is stopping behind my breastbone or is stopping in my neck." Okay. Now, the sensation of food sticking in the gullet is that is what we call dysphagia. Now, that dysphagia can either be oropharyngeal or esophageal. Okay. Progressive dysphagia, first to solids, then to liquid, is likely indicating a structural abnormality. So something is causing a narrowing of the esophageal lumen. Okay. Occasionally, you get dysphagia to both liquids and solid that gradually progresses. Okay. And that usually is a neuromuscular problem. You can get that in conditions like achalasia. Okay. Sudden dysphagia is likely to be oropharyngeal dysphagia from a CVA. Very rarely you will get a sudden dysphagia in the esophagus itself. You get that when you have a bolus obstruction, but that is an impaction, which is an emergency. Now, oropharyngeal dysphagia, like I said earlier on, okay, is a neuromuscular problem and is usually difficulty emptying material from the oropharynx into the esophagus. You get that in conditions like motor neuron diseases and brainstem conditions. And esophageal dysphagia, we did talk about that briefly. More common causes: malignancy, achalasia, esophageal web, and strictures. Now, remember, strictures can either be benign or malignant, or they can be an intrinsic or extrinsic. So benign, malignant, intrinsic strictures or extrinsic can be compression of the esophagus. Now, the esophagus runs very close to the heart in the posterior mediastinum. Now, if the heart is dilated, it can compress the esophagus. Equally, if you have a lung cancer, it can compress the esophagus. So you can have extrinsic compression of the esophagus that can cause dysphagia. Heartburn. Heartburn is a sensation of a burning sensation behind the breastbone. Okay, it's usually episodic, okay, and it commonly occurs after meals. It's usually worse on lying down, and basically you realize those are indications that this has to do with gastric content coming up. So it's usually an acid reflux that is causing the heartburn or a gastroesophageal reflux, and commonly relieved by antacids. Dyspepsia is another symptom that usually when somebody comes and says, "Doc, I suffer with dyspepsia," I usually ask the person, "Do you have any medical knowledge?" Because dyspepsia is not a common man language. It's usually a language from a professional. Dyspepsia refers to any discomfort in the upper abdomen or lower chest, okay, that is related to eating. So if it is not related to eating, it is not technically dyspepsia. The discomfort can be described as a burning sensation, as a heaviness, or an ache. Okay. And usually it's accompanied by other symptoms such as nausea, sensation of fullness, or burping, belching, eructation. Now, abdominal pain, it is very important. This is a very important symptom of the gastrointestinal tract. Okay, and as I've written there, this is a quote I got from a paper. Say, pain is always subjective, and if the clinician does not understand a presenting pain pattern, the chances of justly handling and treating the patient are limited. So you can realize how important it is if a patient comes to you with pain to actually clearly understand what that pain is. Because if you don't understand the pain or the characteristics of the pain, you are likely to miss the cause of the pain and consequently likely to treat the patient wrongly. Now, when we have a patient with abdominal pain, things that we need to take into consideration: one is the location of the pain. Okay. Two is the radiation of the pain. Is the pain fixed or is the pain radiating to other areas? Okay. the character of the pain. Is it a constant pain? Is it a waxing and waning pain? Is it a sharp pain or is it a dull ache? Okay, so all of those things are very important. It's also important to know the duration of the pain, because if the pain lasts a few seconds, it's unlikely that that pain is going to be due to something you will identify on any kind of investigation. If the pain lasts hours, it's actually attributing to something else. If it lasts a day or 2 days, you can actually identify what might be responsible for that pain from those characteristics. Equally important is whether there are exacerbating or relieving factors. So what makes the pain worse? What makes the pain better? Two simple questions. They always help. Now, abdominal pain, I like identifying what is visceral and what is parietal pain. Okay, and parietal pain is actually localized where the pain is, whereas visceral pain is a bit more complicated, more difficult to characterize. Now, visceral pain in the GI tract can occur when you have a sudden blockage of a viscus. Okay. So if you have something that is blocking a tube, you will get pain. Okay, so they are caused by obstructive lesions of the intestines and bile ducts. So any obstructive pathology of a tube. Okay, these pain are actually deep and poorly localized. They're described usually as cramping. And if there's any associated mucosal inflammation, the pain is even worse, and the threshold for pain is very low. Now, if the visceral pain is due to injury to the capsule encapsulating the organ, like liver capsule pain, then the pain is deep but sharp and is actually localized where the organ is. Now, why do we get referred pain? I'm sure you guys must have heard of referred pain. Now, referred pain is actually when you feel pain in an area where the damage or the cause of the pain is actually located somewhere else. Okay. The reason why we get referred pain is probably due to peritoneal involvement. Okay, so that's irritation of the parietal peritoneum. Now, if you have irritation of the parietal peritoneum overlying the structure that is painful, then your pain will be located where the organ is. And that occasionally is as a result of nerve supplying both the parietal peritoneum and the capsule of the organ. Occasionally, the nerve supply may actually be in a remote location, and then you get pain referred to other places. For example, people who have gallbladder pain can tell you that they got pain in the shoulder tip. Now, if we talk about the next symptom, nausea and vomiting, they are quite common, quite difficult to understand and to interpret. But if you can identify that nausea is the feeling of being about to vomit, okay? It's not just any funny feeling, but you feel like you're going to vomit. That is what nausea is about, and it's usually caused by labyrinthine stimulation. Okay, so you get stimulation of the labyrinth in the middle ear, or you get distension of a hollow viscus. At times, some drugs or severe pain can provide similar sensation. Vomiting, like I explained earlier on, is a forceful ejection of stomach content. Now, it's very important that we identify the forceful ejection of stomach content. Okay, why do I say forceful ejection? Because if there is no express effort to expel gastric content, then that is regurgitation. Okay, and that could be because there's a permissive passage between the stomach and the esophagus. Whereas vomiting, you have to have a coordination of various neuromuscular activities that will actually propel the gastric content up through the esophagus, and that needs relaxation of the gastroesophageal junction. Okay, so vomiting is usually preceded by nausea. Okay, And if you try to vomit and you don't bring up anything, that is called retching. So people can also complain of retching. Okay, as I explained earlier on, vomiting is a reflex act. Okay, and that reflex actually is coordinated from the vomiting center in the medulla. Now, most causes of nausea and vomiting, okay, are associated with abdominal pain for GI problems. Okay, and painless vomiting should make you think that the cause is not actually from the GI tract and is likely to be a neurologic problem or a biochemical abnormality. Once again, I must reiterate, it is important to distinguish between vomiting and regurgitation. Hematemesis and melena. Now, hematemesis is the vomiting of blood. So the blood can be fresh or it can be digested blood. Digested blood usually is referred to as coffee grounds. Melena is the passage of a black tarry stool with a characteristic smell. I would like to highlight a little bit of importance about identifying melena. Now, first and foremost, take note of the spelling. It's A-E-N-A. So I have a colleague of mine who keeps bullocking the junior doctors for getting that spelling wrong. Now, what is melena? Melena is blood that comes from the upper digestive tract, anywhere above the ligament of Treitz, that has had an interaction with gastric acid and digestive enzymes. It actually comes out black and tarry and has an awful smell. Blood in the bowel can also be black in color, but it's not melena. The reason I specify that is because melena means an upper GI tract bleeding and indicates the need for a gastroscopy. Blood per rectum, whether it's black or not, needs a colonic examination. Now, how do you distinguish them if you're not clear? If you use a white piece of paper and rub melena, the paper will be black. If you use a white piece of paper and rub blood, dark blood, that will still remain red. So it's very important for those junior doctors and medical students to make that distinction. Because I, as a gastroenterologist, if you tell me a patient has melena, I am thinking of doing a gastroscopy until proven otherwise. Now, somebody can have an upper GI blood loss and have bright red blood per rectum. That is still acceptable, but that means the person has a brisk blood loss. Don't call it melena. The person has got blood per rectum, but you suspect an upper GI tract blood loss. And you must have your own reasons why you do that. So maybe on one of our talks, we'll actually explain upper GI bleeding. Now, symptoms of the lower GI tract, like I said, constitutes flatulence or bloating, constipation, diarrhea, abdominal pain, rectal bleeding. Okay. Now, let's start with the flatulence, okay, and the bloating. Flatulence and bloating is practically gas. You pass gas from the back passage, okay. 75% of that gas comes from the colon with bacteria causing fermentation. And as you can see, that is actually dependent on the food you send to the colon and the bugs you have in your gut, okay? So that combination will generate certain type of gas, and 75% of that is actually coming from that fermentation process. 25% comes from diffusion from the bloodstream. Although I've written here aerophagia, very rarely gulping of air comes out of the bottom passage. Now, this is important because aerophagia is the commonest cause of eructation. I did mention earlier on that eructation is an upper GI symptom, but I want to discuss that as part of flatulence because that is all gas. Now, eructation is burping, expulsion of gas through the mouth, and that gas is normally localized in the upper digestive tract. So it can be in the esophagus, it can be in the stomach, very rarely in the duodenum. That eructation is from gas that is consumed when we are talking, drinking, aerophagia. At times is gas diffusing from the bloodstream. It is very, very rarely due to bacterial overgrowth in the upper digestive tract. It can also happen in the context of gastroparesis, where you have stasis in the stomach. And as such, there's a buildup of gas. There are certain pervasive conditions that will allow fermentation in the upper digestive tract, and that will produce gas to cause eructation. Okay, so here are the main complaints: eructation, distension, and flatulence. Now, constipation. It is very important to actually clarify when a patient says, "Doc, I am constipated." It is important to clarify what the patient means. Technically, constipation means passing less than 2 bowel movements a week. Okay. Personally, I classify constipation as difficulty opening your bowels of very hard stools. So you can have a bowel movement every day. If you find it difficult to expel the stool and the stools are hard, I will consider that being constipated. I have patients come to my clinic and tell me, "Doc, I am constipated. I go to the toilet once every 3 days. Are your stools hard?" "No, the stools are soft and I have no problem opening my bowels." Now, that to me, that is not constipation. That does not warrant medical intervention. That is just your normal functioning. And vice versa, like I said earlier, on somebody going to the toilet on a daily basis, but having very hard stools. Now, that person is constipated and needs assistance. Now, constipation is usually characterized by difficult or infrequent passage of stools, like I said, hardness of stools, and feeling of incomplete evacuation. Okay, it can be acute. Usually, acute constipation is an organic problem or drug-related. A chronic constipation is usually functional. It is very rare for somebody with bowel cancer, for example, to come and say, "Doc, I've been constipated for 5 months or for 5 years." That is not, it's not likely to be bowel cancer. Okay. Diarrhea, which is considered the opposite of constipation, is defined as increased stool fluidity and increased bowel frequency. Okay. Now, I would like to highlight the plus or minus that is written on that slide. So the initial problem with diarrhea is increased stool fluidity. That is diarrhea. You might have associated increased bowel frequency or not. Somebody with increased stool fluidity, opening their bowels once a day, to me, still has diarrhea. Technically, diarrhea will be somebody who opens their bowels more than 3 times a day of liquid stools. Usually, this is the result of an imbalance between fluid absorption and secretion into the gut. There are various reasons why that could happen. Okay. Now, some of the reasons is when you have water-soluble solids that remain in the bowel. These solids tend to attract water, they keep water, they make the stool fluid. We use these characteristics of certain solids to help us in our medical practice. In fact, when we give bowel preparation for investigations or for surgery, that is what we are trying to do. We do that by giving people PEG solution. When people come constipated, we give them things like macrogol. That is what we are trying to achieve. We give them magnesium salts. That is what we are trying to achieve. So magnesium salts will stay in the gut and they will attract water and they will encourage loose or soft stools. At times we do them involuntarily when we eat poorly absorbed sugars, something like hexatrol or sorbitol that you have in most of these diet sugar-free drinks. So consuming large quantities of that can also lead to diarrhea because of inabsorbable sugars. Okay. People who suffer with lactose intolerance, what happens is that they cannot digest lactose. So lactose gets into their gut, and the lactose is a sugar, it's a solute that will retain liquid and will cause diarrhea. Lactulose is another product that we use medically for those same reasons, to increase stool, to soften the stools. Secretory diarrhea, on the contrary, is where the bowel wall or the gut is irritated and is stimulated to actively secrete solutes or fluid into the gut to cause diarrhea. And that usually comes in the context of infection like cholera, inflammation, some endocrine tumors like VI poma, and unabsorbed dietary fats and bile acids. So you have bile salt malabsorption, they will cause secretory diarrhea. Rectal bleeding, also called hematocatia, is the passage of frank blood per rectum. Okay. Now, it's important to quantify the amount to try and identify the origin. Bright red blood on the tissue paper is likely coming from the anus, from the anal margin. It's unlikely to be a colonic bleed. Bright red blood coating the stool is likely to be from the rectum. It is unlikely to be blood that is coming from anywhere else. Now, if the stools are mixed with blood, it's likely that that bleeding is somewhere in the sigmoid or descending colon. And the reasoning behind that is that stool in the right colon or the transverse colon is usually liquid. So if there is any bleeding in that area, the blood will mix with the stool. Okay. By the time the stool gets into the left colon, so the descending and sigmoid colon, the stool is already formed. So bleeding from those areas tend not to mix with the stool, they tend to coat the stool. Okay. Now, so rectal bleeding usually originates from the left colon, okay? Diverticular disease, inflammatory bowel disease, those are common causes of rectal bleeding, okay? And like I said, if the blood is just on the tissue paper, it's likely of perianal origin. I think I'm going to skip this slide here, and we're going to come to the signs, okay? Now, when it comes to signs, it's actually a bit more difficult to split the signs from the upper digestive tract and the lower digestive tract. But as we all know, signs are what the doctors actually identify when they examine the patient. Those of you who were not present when I started the presentation, I said, when I was training, I was taught to identify symptoms. I was taught to pick up signs on examining the patient. And when I had those information to hand, then I will formulate a differential diagnosis and determine what investigations need doing. With technology, I think that doctors of the future, they will not even have that benefit, because the patient will walk to you and say, "Doc, I had a headache the other day, and because my headache was affecting my sight, Google has told me that I need to have an MRI of the brain. So, doc, I have already booked my MRI of the brain. Can you look at the results and start my treatment? I think some of you will be having those things in the future. And the people who make the policies, the governments and the like, they like that kind of stuff because they think it's actually going to make healthcare cheaper. We as doctors, we need to know that we still have knowledge more than what an artificial intelligence paper will put together from a patient. So we can still interact with human beings and understand better what their symptoms are and what the signs they are referring to. And so it's important that we know what those signs and symptoms actually mean. So hopefully, medicine will still have a place in the future. So some of the signs that we will have in the GI tract include pallor, angular stomatitis, koilonychia. These are all signs of iron deficiency, and iron deficiency in the GI tract indicates chronic blood loss or chronic iron malabsorption. Okay. Clubbing, we know clubbing of the fingernails. Okay, it can be just on the fingers, or it can be on the fingers and the toes. Clubbing is not a common GI sign. It's more of a lung pathology or is genetic. Okay, but you can have clubbing in some GI conditions like Crohn's disease. Okay. Leukonychia is white nails. I don't have a slide of that. I think I should include that. But leukonychia is white nails, and white nails is an indication of hypoalbuminemia. Okay. So if you have white nails, it's because there's been a long-standing hypoalbuminemia. What did I have a question? Okay. Okay. Now, white nails, like I was saying, is a sign of hypoalbuminemia, and hypoalbuminemia is a characteristic of somebody who is seriously ill. Now, that illness could be from any organ, but we know the biggest producer of albumin, the main source of albumin in the body is the liver. Okay. So if somebody is very ill, that illness inhibits the liver from producing albumin. And that's why you have hypoalbuminemia. So you have people with white nails. Typical scenario is somebody who has got a leukemia. They have a leukemia, they get treated, they go into remission, then they relapse, they get treated again, they go into remission. If you look at their nails, they have band leukonychia. So they have lines, horizontal lines of white nails, okay? So that is band leukonychia, and that is a typical sign of somebody who has a condition that has been in remission and flare-ups and remission and flare-ups. Spider nevi is a condition you find in liver disease patients. Most of these conditions that we're talking here in terms of signs, okay, they are all of the accessory organs. The ones you find, the signs you find on examination from GI tract problems, very strange, I did not put them down, is things like the tenderness you get on examination, or the guarding, and I think I'll talk about that in a minute. Before we go and talk about these things, let's try and simplify our understanding of the gastrointestinal tract and things like that. So the abdomen in itself, most people will divide the abdomen into these 9 regions. Now, these 9 regions make it quite challenging to identify various organs. So people tend to go down to 4 quadrants. So you will hear a lot of people talk about the right upper quadrant, the left upper quadrant, the left lower quadrant, and the right lower quadrant. At times, the right lower quadrant is referred to as the right iliac fossa, and the left is referred to as the left iliac fossa. Okay. Now, it is very important, this arrangement. And the reason why that is very important is because when you divide your abdomen into these quadrants, you get conditions like these conditions on this slide that are definite in those areas. Okay. So somebody with a right upper quadrant pain is very, very unlikely to have a rectal pathology. Okay. So if you see somebody who has got a right upper quadrant pain, don't come and tell me at the exam that this person has got rectal cancer, because you have failed. Okay. And it's the same thing when you look at the left lower quadrant or the left iliac fossa. The symptoms you can get, the organs that can cause symptoms in those areas have been written down there, and we can have a discussion in the chat section. Now, on examination, like I was saying, now we were taught to examine patients using using the 4 key pillars of physical examination. So inspection, palpation, auscultation, and percussion. Okay, so you inspect the abdomen. Usually when you're examining your patient should be lying supine with their head on one pillow. And you, the doctor, you should be at the level of the abdomen. Okay, so the level of the abdomen should be where your palm can actually lie on the abdomen. So you examine the abdomen with the palm, not with your fingertips, with your palm. Okay, you inspect the abdomen for size, shape, and any irregularities. You look for movement artifacts or visible peristalsis. You palpate the abdomen first with the flat hand to look for abnormal guarding. Oh, come on. To look for abnormal guarding, okay? Technology, sorry about that, okay? Now, when examining the abdomen, you are looking for spasm or rigidity. These are involuntary contractions of the abdominal musculature. Now, spasm or rigidity, because they are involuntary, what that tells you is that the body is trying to protect the person from pain, okay? So that is an involuntary action, and usually is because there's an underlying inflammation, okay? So you get that when there is peritonism, okay? You get spasm, rigidity. Guarding, on the contrary, is a voluntary action. So the patient is at ease until the patient anticipates you are going to examine them, okay? So when they anticipate you're going to examine them, then they contract their muscles. It's because they are anticipating to be in pain. So they are trying to protect themselves, okay? And that is very important to clarify. So you can actually divert the patient's thinking from the examination to identify guarding. Percussion, when you percuss the abdomen, you are percussing the abdomen for the liver, for the spleen. You identify shifting dullness in case of ascites or distended bladder. And auscultation, you listen for bowel sounds. In the context of paralytic ileus, there are no bowel sounds, so you got to silence. In the context of obstruction, if it is acute, you get active bowel sounds. At times they tell you get tinkling bowel sounds. Okay. You also listen for bruits. Bruits are actually presented by obstruction in blood flow, particularly when you have things like renal artery stenosis and that sort of stuff. You get bruits. You can also get bruit in the liver, which is very rare. In textbook, they will tell you that a liver cancer can produce bruits. That is extremely rare. So those quadrantic representations I showed earlier on, here are some of the conditions you would find in those quadrants. So if you find a pain in one of those quadrants, it's likely to be any of these conditions. Now, I think I have managed to run through some of the symptoms and signs of upper digestive, of GI disorders. I don't think I've actually covered everything, but I hope I've been able to give people some food for thought, and so they can actually start asking questions and see whether we can expand our coverage. Any questions?
I got 2 questions, please.
Yeah, who's talking?
It's a Jenny.
Yes, Eugenie.
Yeah. Can I go?
Yes, go ahead.
Okay, yeah. Thank you for your really informative presentation. I would like to ask if the hiccup is considered as a gastrointestinal symptoms or neurological symptom.
The what?
Hiccup.
Hiccup. All right.
Yes.
Okay.
Okay.
Well,
My-
that is quite a difficult one, because hiccup usually is an irritation of the diaphragm.
Yeah.
Now, I have patients come to me with hiccups, but I don't normally. What I look for is whether there is evidence of a subphrenic abscess.
So friendly. Okay.
Yes.
And how do you do that? You do any scan?
That is the first thing to do.
Yeah.
If at times the hiccup, they can tell you if somebody has been having hiccup for 5 years, is not likely to be a subphrenic abscess. You do a simple blood test, full blood count, and will tell you if the white count is elevated. If they have a subphrenic abscess, their albumin will be low, so they will have hypoalbuminemia.
I mean,
So,
yeah.
yes, if somebody has got raised white count, low albumin, and a hiccup, yes, I'll do a CT scan. I'll look for subphrenic abscess.
Okay. My second question is regarding the heartburn. If you have patient with heartburn and the barium swallow show esophageal dysmotility, can this be pinpointed as the cause of the reflux? And if yes, a part of the PPI, what could be another treatment, please?
Usually that question goes beyond the student level, but I will explain. I'll answer your question.
Sorry, I took the place of student.
I'll answer your question. Now, heartburn is definitely a symptom that refers to acid reflux. So whatever is causing the heartburn comes from the gastric cavity into the esophagus. If a barium swallow shows esophageal dysmotility, I'm not convinced that esophageal dysmotility will present as heartburn. So if there's esophageal dysmotility on barium swallow, I tend to do an esophageal pH and 24-hour manometry. Sorry, an esophageal manometry and 24-hour pH study. Because that actually tells me if I've got acid reflux and also classifies the dysmotility. Now, if the dysmotility is as a result of esophageal contractions, the treatment is a calcium channel blocker, like nifedipine, typically nifedipine.
Okay.
Yes, but if the problem is acid reflux, then we know that the best treatment is anti-reflux surgery.
Yes.
That is the best treatment. Now, anti-reflux surgery, some years ago, anti-reflux surgery was done by major thoracotomy. Nowadays, anti-reflux surgery is laparoscopic fundoplication. Okay. And that is very quick, very straightforward, 4 hours in hospitals. It's a 30-minute operation. And I'll tell you, in the future, anti-reflux surgery will be endoscopy, day case. And that is already being done. So we have endoscopy that will do a fundoplication endoscopically.
Okay, thank you so much. Thank you. Thanks a lot.
Yeah.
Yes.
Thank you very much, Dr. Theo. But I just wanted to remind all the participants to fill in the survey, which is in the chat link, which Dr. Bello has posted, please. That's going to help us with future planning. You can carry on with the questions.
Yes, Dr. Ngatchu, is Dr. Bello here.
Yes, thank you.
There's 2 questions for you on the chat.
Yes,
I don't know
please.
if they want to say it
Yeah.
themselves or if you can just read it.
Oh, go ahead, go ahead. I'm doing this thing off the cuff.
Okay, so question from Dr. Obale. What about hepatic flap? Confusion sometimes in patients with liver problems.
Yes, I specifically did not discuss liver disease because I think that would be the topic of another conversation.
Okay.
It's a condition that is very close to my heart. Yes, but liver flap, they refer to liver flap. I call it metabolic flap. Okay, that flap you get in liver disease is a metabolic flap. It is not unique to patients with liver disease. It is an indication of encephalopathy. Okay, but you get that also when people have got CO2 retention. You get the metabolic flap.
Yep, that makes sense. And then the next question, Sister Anne, I can see your hand up. Let me just ask Dr. Ngatchu this question and then he'll come to you. This one is from Cynthia Degala, and she followed it from Cameroon. Thank you, Cynthia. She wishes to clearly understand the difference between osmotic and secretory diarrhea.
Right. Now, Cynthia, is very simple. Usually in secretory diarrhea, the body is actively secreting material into the lumen. Okay. So the material that's been secreted into the lumen comes from the blood circulation. Whereas in osmotic diarrhea, the material that causes the diarrhea is actually inside the lumen. Okay. So in secretory diarrhea also, what you get is you don't only secrete the solute, you also secrete the liquid. Whereas in osmotic diarrhea, the solute is within the gut. Okay, so usually in osmotic diarrhea is something you take orally, and that stays in the gut. Whereas in secretory diarrhea, there is something that is actually interfering with the mucosal barrier. Now, that might be a bit more technical, but basically osmotic diarrhea is something you take orally. Yeah. And secretory diarrhea is usually due to inflammation. For things like, in places like Cameroon, the likely things are an infective process that causes secretory diarrhea. Yes, Sister Anne. You are muted. Unmute yourself.
Unmute, Sister Anne, please.
Okay. Thank you for this brilliant presentation. It was really great. It really simplified a lot of things about the GI system. And please, can I just ask, what will be your approach to upper GI bleeding, which we often see as coffee ground vomitus, and your rationale about it?
Right. Right. And I was actually going to organize to do another talk on upper GI bleeding.
Okay.
Briefly, what is important to identify in upper GI bleeding is whether that bleeding is active, ongoing, or has happened and is no longer active. Then there are two reasons for that. If the bleeding is active, ongoing, then you need somebody to stem the bleeding to save a life.
Okay.
If the bleeding has happened, then what you need is you need a risk stratification, whether that person is going to rebleed or not. Both of them carry different urgency. The one you need when somebody is actively bleeding, you need an urgent intervention, okay? So that is where you have emergency GI bleed on call.
Okay.
The one for risk stratification, that's a diagnostic endoscopy. You can do that anytime.
Okay, thank you very much.
Welcome.
Dr. Ngatchu, Dr.
Yes.
Bello here. I have a question about constipation. So
Yes.
I'm a GP, as you know.
That is very common in primary care.
Very common.
Yes.
So I've got lots of patients on laxatives,
Yes.
you know, all sorts. You know, I was wondering if you could, and a lot of them are a bit apprehensive about being on the laxatives for a long period of time. And they, you know, even the younger ones, they think, oh God, I need to stop it in a week. Do you have any tips, one on obviously how long is a long time to be on it? And if we're going to use specific ones, which ones should we use? Again, I've hijacked this presentation for my own purpose.
Now, I think it's a very important issue because a lot of not just doctors, but even parents and friends and the like will be faced by somebody talking about being constipated. Now I think what is important is first and foremost for the person to understand what they mean by constipation, okay, and to know what they're actually trying to resolve. Because if they are trying to, I don't know, but in some communities, people feel they must open their bowels every day at a specific time. And if that doesn't happen, they feel they're constipated. Now, if you're having a problem because the person is having very hard stools, then the best way to help them out is to find things that will soften their stools. That's why you give people macrogol and laxido or laxido. Okay. Now, what you can help that process by increasing the fiber in their diet. Mm-hmm. Now you have some fibers that are soluble, others that are non-soluble. Now the soluble fibers tend to produce less gas. Now fibers, when they get in the colon, they get fermented by bugs and produce gas. Okay. So the patient needs to be aware that the more fiber they have, the more gas they produce. So it will help one thing and create another problem. Okay. Now, if their problem is actually stool frequency, then they are looking for something that is a prokinetic. That's when people take things like Senna. Now, naturally, you don't have things that will actually move your bowel that quick. You expect the bowels to move spontaneously when they feel full. Okay. So you give them bulking agents, broccoli, carrots, and all of those things. They are bulking agents. Cereal that people have every day. Those are bulking agents.
Thank you, very useful. And is there any specific laxative that you'd be happy to say, okay, well, because obviously we have the elderly, they're lying in their bed, they're not walking around, they're on lots of opiates, morphine, bowel sluggish. In that case, what is there a specific laxative we should use, bearing in mind that we know that it's going to be long-term?
Now, you can use macrogol anytime. Macrogol does not get into the system. So you can use any of those osmotic laxatives. Mm-hmm. Macrogol is a typical one because it does not cause bloating. Lactulose will cause bloating because it's a non-absorbable sugar and is fermentable. Okay, so you have those two that you can use all the time. But if somebody has been taking opiates for quite a long time, their problem is they also have a sluggish gut, so they need something to help move the gut. They need some prokinetic added to that, So and in that situation, they will struggle to find something natural, need help. There is a new drug on the market called naloxone, which blocks the effect of opiates on the gut.
Very interesting. I hope I'll see if I'm able to prescribe that.
Check it out.
I'll check it out. Thank you so much, Dr. Ngatchu.
Right now, I don't see any more questions. I would like to thank everyone for joining.
Dr. Theo.
Yes.
I can see from the chat somebody from Cynthia Delega.
Yes.
We answered that already, Anna.
No, she's put
another one
now. Saying, I have a worry. I just received the link from a friend. I wish to know how I can do to be able to be more highlighted about further Zoom teachings.
Ah, okay.
Right.
I think we share the links on different platforms.
Mm-hmm.
And so it's just to check. I don't know if
could we take her details?
Yes.
Could we take her details and we inform her on future teachings.
And also it's very straightforward, CamDocUK.org. That's
Right,
the
okay.
website.
It's on the website, yeah?
Any further teaching will be on our website,
Good.
CamDocUK.org.
Can,
So I'll put that on the chat just now.
yes, if you just put that on the chat, then she'll probably pick that up.
Okay. And we're also, if you follow us, Cynthia, on Instagram, Twitter, Facebook, we put all these things on there as well. So you won't miss it. I'm just putting all our handles on the chat as we speak. And actually, for those that are here, we have I'm going to use two hats. My name is Dr. Bello. I'm the chairperson of CamDocUK. We have a webinar this evening at 6 o'clock on COVID